Okay, so after that, we will move forward through the clinical evaluation of a case of glaucoma. So, as Hamlet said once, to be glaucomatous or not to be glaucomatous, this is the question. Actually, Hamlet didn't say that exactly, but we will just borrow his sentence, to be or not to be, that is the question, because to be glaucomatous or not to be is the question for an ophthalmologist. Like, if this patient is glaucoma or not glaucoma, because if you are calling a patient as a glaucomatous, you are putting him in the glaucoma prison. He will be present within the anti-glaucomatous medications for his entire life. That's why it is very important to have the correct judgment. To say that the patient is glaucomatous, this means he is glaucomatous. To give him to have a rationale for the anti-glaucoma management that this patient will suffer all his life. Also, if you are saying that this patient is not glaucomatous, this also should be justified. You should have enough clues to say that this patient is not glaucomatous, so that you are not jeopardizing the patient's quality of life and the healthiness of his optic nerve by making him like a false negative, saying that he is false negatively that he is not glaucomatous. Okay. So how can we reach such a judgment? This is by the clinical evaluation. To make or to say that the patient is a glaucoma suspect, we need to have clues from history, examination, and investigations. By history, starting by the risk factors that we just mentioned, the steroid use will also play a role, and also need to ask a history about the treatment complications. The examination by measurement of the intraocular pressure correlated with the central corneal thickness, the gonioscopy, and finally the optic disc. Investigations by the visual field and optic disc imaging, like by OCT or optical coherence tomography, and HRT, which is the same like the OCT or what's called Heidelberg retinal tomography. So starting by the history, what should we ask in the history in order to exclude, or what you might find in the history, in the scenario, in the exams that will give you an alert about the glaucoma? These factors, like the age, as we mentioned, that most cases of primary glaucomas will present after 65 years old. So the higher the age, the more the risk. And the race, also the earlier onset and the more severe onset on blacks. So I'm speaking again about primary open-angle glaucoma. Inheritance, this is also very important. The risk, the family history, as I told you, because the family history, the risk is increasing by two-folds if the parent has primary open-angle glaucoma, and it is increasing by four-folds if the sibling has primary open-angle glaucoma. So I remember this was a question to me in the FRCS3 exam, when the examiner showed me a picture of an optic disc cupping, and he kept asking me about the risk factors. So I told him about the age and race, and the refractive error, and so on, so on, so. And he was waiting for me to just say the family history, that I need to ask about the family history of a parent having primary open angle glaucoma, or a brother or sister having primary open angle glaucoma. This will change the rules of the game dramatically. Myopia also, which has been linked to primary open angle glaucoma. We need to ask about the steroid use, and also need to ask about the treatment complications. Like if you are going to give this patient certain anti-glaucoma medications, the most important in anti-glaucomatous medications, as we are going to mention the next lecture, is to know when not to give it, when it is contraindicated. So this is important for the practice and important for the exam. Like if a patient has bronchial asthma or heart failure, we shouldn't give them beta blockers. The patients who have renal stones, we shouldn't give them carbonic anhydrase inhibitors. The patients with allergies, like also sulfur allergy, we shouldn't give them carbonic anhydrase inhibitors, and so on. So we need to inquire about the anti-glaucomatous or the treatment complications, or complications that could result from anti-glaucomatous treatment. Then the examination, You will just proceed with the examination like as usual by recording the visual acuity, keeping in mind that primary open angle glaucoma will affect the visual acuity late in the disease. Checking for the media clarity, like the presence of hyphema or vitreous hemorrhage or cataract. These are maybe the cause of the high intraocular pressure. So, and then check for the cause, like for the lens, if there is any kind of lens-induced glaucoma, for the iris as in pigment dispersion syndrome. So here is the thing that you diagnose a primary glaucoma after exclusion of the secondary causes. So we can't say that the patient has a primary glaucoma unless that the patient doesn't have any secondary causes. So by confirming that every ocular structure is normal, then that's when we can say that it is a primary angle or primary glaucoma. You check the intraocular pressure with correlation of the central corneal thickness, checking the angle by gonioscopy, and the most important is to do stereoscopic evaluation of optic disc. So this will be very, very important in order to follow up those patients. So we talked about the intraocular pressure and its relation to the central corneal thickness. Let's now talk about the gonioscopy. So the gonioscopy, there are certain structures present in the angle. Starting from anterior to posterior, there will be the Schwalb's line, then the trabecular meshwork, then the scleral spur, and finally the ciliary body band. Again, from anterior to posterior, there will be 4 structures: Schwalb's line, trabecular meshwork, then whitish band called, or whitish line called the scleral spur, then brownish, what will be the ciliary body band. So if we find that the 4 structures are present, we call it like grade 4 or open angle, according to what's called Scheffer classification. So Scheffer classification is a classification to the angle depending on how much structures that are visible. So grade 4, you will find the Schwalb's line from anterior to posterior, Schwalb's line, then trabecular meshwork, then the scleral spur, and finally the ciliary body band. So all 4 structures are present. In grade 3, you will find the ciliary body band is not visible. So you will only check, you can also detect, or you can only detect the Schwalb's line, trabecular meshwork up to the scleral spur. So this is called grade 3. Grade 2, you will be able to only detect the Schwalb's line and trabecular meshwork. For grade 1, you will only see the Schwalb's line. If grade 0, so there will be no structures of the angle are visible, or what's called iridocorneal contact or iridocorneal touch. So the angle here is totally closed. So this is for the gonioscopy. Let's now talk about the optic nerve head assessment. So we said that we need to do stereoscopic image of the optic disc. So how can we assess the optic disc? We start first by assessment of the size. Like you may find that this patient has cupping, or you say that this patient has cupping, but however, this is not a cup. This patient has large cup, but also large optic disc, because this patient has a myopic disc. And on the other hand, this patient has a small disc and the crowded disc with a small cup and a small disc. So we always judge the cup in relation to the size of the disc. So we cannot say that it's always a large cup, but we need always to check the size of the disc in order to exclude the patient could have large cup and large disc, like a myopia, or small cup and small disc in hypermetropia. The symmetry between the 2 cups was found to be one of the most important clues. It is not diagnostic, but it is very suggestive that if there is asymmetry between both eyes more than 0.2, more than 0.2, like if this patient, for example, he is almost having 0.5, and this maybe 0.7. So if there is difference of 0.2 difference between both eyes or more, this will be suggestive of glaucoma, of glaucomatous damage. So the cup disc ratio is the difference or the ratio between the cup to the disc. So the disc here, let's see for those who don't know. So this is the disc. This is the boundaries of the disc. And this is the boundaries of the cup. So the cup to disc ratio or CD ratio indicating that the thickness of the neuroretinal rim. So if there is increasing in the cup to disc ratio, meaning that there is thinning of the neuroretinal rim. And how can we measure this cup to disc ratio? It will be by measuring the thickness of the neuroretinal rim. And this can be done from the scleral ring, which will be like this halo around the neuroretinal rim, to the cup border where there is bend of the blood vessels. So we have two anatomical landmarks. The edge of the cup is marked by the bend of the blood vessels. And the outer edge of the neuroretinal rim is marked by the scleral ring. Okay, so by comparing the size of the cup to the size of the disc, we know how much thickness of the neuroretinal rim should normally be around 0.3. If the cup is increasing in size, like becoming like that, so the amount, the neuroretinal rim will becoming very thin, like it will be. So if it is, the larger the number, the worse the condition. So if it is becoming 0.5, 6, 7, 8, 9, 0.9 meaning that there will be very, very thin rim, and the all cup or all disc is replaced by the cup. And if it is no cup, then, or there is there will be 1, so there is no progressing from 0.9 to 1, then this means that there is an optic atrophy. There is no remaining neuroretinal rim, and this will indicate like an end-stage case of glaucoma. So we want to preserve the healthiness of this neuroretinal rim in those patients with glaucoma, preventing further progression in the glaucoma. Okay, so this neuroretinal rim is present or it is different in thickness in the inferior optic disc to the superior, to the nasal, to the temporal. It will follow what's called Isent rule. Isent rule is that the inferior rim is thicker than the superior, thicker than the nasal, thicker than the temporal. So the thinnest will be the temporal, and the thickest will be the inferior. That's why in the patients with glaucoma, the most important is vertical cupping than the horizontal cupping, because in the vertical cupping, this indicates that the inferior and superior are involved first. So that's why we check for the vertical cupping will be more significant of early glaucomatous damage. Okay. Do you see here the rim thickness? You see that should follow the Isent rule, inferior, superior, nasal, temporal. But the inferior rim here is very thin. You see the kink of the blood vessels? It will like the rim here is almost like 0.7 or 0.8. So it will be, and while the superior rim is still more healthy, and the temporal and the nasal, but you see, by the way, this is the nasal and this is the temporal, because there is nasal shift of the blood vessels. So this will be more indicative of an ongoing glaucomatous damage. Another thing that can be suggestive of glaucoma, one of the dilemmas is whether this optic disc is glaucomatous or neurological. So another important sign here in the optic nerve assessment is the amount of pallor. So we have a cup and we have a disc. If the amount of pallor is more, or if the cupping is more than the amount of pallor, then this means that this patient is glaucomatous. So here the patient is having the reverse. Let me again repeat. If the patient has cupping and the amount of cupping, the extent of the cupping is more than the extent of the pallor, then this means this is a glaucomatous optic disc. The reverse will happen with the neurological. So if a patient has more pallor than the cupping, then this means that it will be a neurological optic disc. So it is a matter of comparison where what will be the more extensive or more extensive. So pallor here is a very important sign to differentiate between glaucomatous and neurological. Optic disc hemorrhage, also very important sign of an optic disc compromise, especially in patients with normal tension glaucoma. Normal tension glaucoma is characterized by increasing significance and increasing incidence of optic disc hemorrhage. Also, the presence of notch. This notch meaning that the inferior, the rim is almost vanished. There is no neuroretinal rim. So it will be replaced by a notch. So this notch again is suggestive of glaucoma. And at the area of this notch, you can see that the blood vessel, you cannot see the remaining part of the blood vessel. So this blood vessels, you see, it is reflecting, or there is kinking of the blood vessel. But where is the kink here? There is no kink because the blood vessels is buried inside the optic disc because there is no neuroretinal rim, no anywhere. That's why this sign is called the bionetting of blood vessels. Bionetting of the blood vessels. Okay, so it will happen at the areas of notch. Nasal shift of the blood vessels also will be a sign of glaucomatous damage. So you see here are the major arcades. The upper temporal, lower temporal, upper nasal, lower nasal will be more shifted nasally. And also there are the peripapillary changes. So if we find a patient or that like check the peripapillary changes, that's why I'm telling you that serial photographing of the optic disc is very important. You can see that this patient has this whitening this white striations are the striations of retinal nerve fiber layer. But the inferior part here, you can see that there are lost striations of retinal nerve fiber layer, and by follow-up after 6 months, there is increasing in the area of lost striations of retinal nerve fiber layer. So this is indicative of progressive damage to the optic nerve. Also, the presence of peripapillary atrophy. Peripapillary atrophy, like in the bottom, like what happens in myopia, it is not very significant for glaucoma, but it's also a sign. And also there is another areas or what's called zones, which represent what's called beta zone and alpha zone. These are the zones surrounding the optic disc. So beta zone will represent retraction of the RPE from the optic disc margin. And it will, if the presence of this beta zone or the atrophy within this beta zone, this will indicate that it is more common for patients with primary open-angle glaucoma or normal tension glaucoma, and their extent will be correlated with the visual field loss. Outside the beta zone, it will be the alpha zone, which appears as a parapapillary like hypo or hyperpigmentation due to RPE irregularity. It will be also present. It's present outside the beta zone, and it can be present in normal eyes, by the way. So here, the beta zone and alpha zones are may happen with glaucomatous patients, and the beta zone is more significant. So remember, the one which is close to the optic disc is more significant for glaucomatous damage than the alpha zone, which will be occurring more in almost in all normal eyes. So how can we remember, or how can we recall which one is the close to the optic disc and which one will be away from the optic disc? Remember, B for beside and alpha for away. So beta will be beside the optic disc and alpha away from the optic disc. Finally, the investigations. How can you investigate a case of optic of glaucoma? So we have the visual field or the perimetry. How can we interpret the perimetry? We will find some data regarding the patient's information and the test data, like the test stimulus and the background and strategy used, and also the patient's refraction, the patient's age, and the date and time. And there is on the left, there will be the reliability indices, which will indicate if the patient has reliable test or not. So starting from the fixation losses, so fixation losses will indicate the patient is attentive or not, as the device or the perimeter will give a stimulus to his blind spot. And if this patient responds, then this means that he is not attentive. The false positive error or a trigger happy patient, those patients who are responding to the sound rather than the vision of a stimulus. So they will click, or they click on the trigger on hearing a sound, not on seeing the stimulus. The false negative is a patient was also not attentive because this patient failed to respond to a suprathreshold stimulus rather than a threshold stimulus. So if his area of the retina responded to a threshold stimulus, and we are stimulating the same point again by hyperthreshold stimulus, the patient doesn't respond. So there is also another reliability indices called the short-term fluctuations. And these reliability indices will be helpful to know if we can rely on the results on this test or not. So we have then two maps called the gray scale and the numerical scale. So the numerical scale will represent the sensitivity of each point of the retina by testing it through a certain threshold stimulus, and this device will be the higher the response, it will be the normal, and the lower the response, it will be represented in grayscale. So the lower the response or the lower the sensitivity of this part of the retina will be represented by grades of black and gray. And then there is two maps called the total deviation and the pattern deviation. The total deviation will be representing how much each point of the retina is deviated from the normal sensitivity for age and sex of this patient. So like -1, it will be less than the normal of age and sex by -1, but here -33, this means that this patient is below the normal for age and sex in this point by 33 decibel. And this will be represented also in a dark scale, or so there will be a numerical scale, and there will be like a graphical scale. And this graphical scale will be represented by a probability indices. So the darker the spot, or the darker the mark here, represent how much this defect is to be normal, how much probable is it to be normal. So like if it is this black, this is mean that less than 0.5% of normal population have this defect as a normal finding. So the darker the spot, like this black square, meaning that this is away from being normal. This will be more probable to be abnormal. So the total deviation will represent them all the decrease in sensitivity caused by any reason, either regarding to the retina or the optic nerve, or even a media opacity like cataract, or any kinds of media, any kind of media opacity, or a small pupil, or a refractive error. So it is not only related to the glaucoma. Then the device will subtract the pattern deviation, or pattern will subtract the localized defect from the generalized defect in order to come up with a pattern deviation. So this one will be the true representative for a glaucomatous damage. Okay, so the total deviation will be the total for decreased sensitivity for all reasons, while the pattern deviation will be only for the glaucoma or for the specific neurological defect. So it will be more representative for glaucoma, as we are speaking now about glaucoma. These are the global indices. So the mean deviation will be like the mean of all values. So it will be calculating the summation of all values divided by their number in order to come up with a single number that will represent the total deviation of normal. And the pattern standard deviation will be representing the localized defect as well, like in glaucoma. So this will be helpful for follow-ups. Finally, there is a small box called the glaucoma hemifield test, or it can be either within normal limits or outside normal limits, or it can be suspicious. In this test, it will compare certain zones above the horizontal line to the similar zones below the horizontal lines, and check what will be the sensitivity between both upper and lower. As we know, in the case of glaucoma, there will be more affection of the lower field first. So those or the lower retinal fiber layer will be damaged first. That's why it may show earlier decrease in sensitivity. So when we are comparing between them and the lower and the upper, this may be indicative of an early glaucomatous damage, and it will be represented here in the Humphrey visual field by the outside normal limits. Okay, so this is the visual field in a nutshell. Let's now see the patterns which will maybe we could find in the glaucoma. So in the visual field on the primary open angle glaucoma, there are some characteristic visual fields like nasal step. This is called the nasal step, which will be suggestive of an early glaucomatous damage. Or there could be a paracentral scotoma. Paracentral scotoma will be also suggestive of an early glaucomatous damage, or can also be more specific to normal tension glaucoma. But by the way, it is not specific for glaucoma. It can happen with the neurological field effects, as we mentioned in the neuro. But speaking about the glaucoma, paracentral scotoma can be associated with early glaucomatous damage or normal tension glaucoma. A temporal wedge like that is less common, but also can be suggestive of primary open angle glaucoma. Arcotoscotoma. This is very suggestive of glaucomatous damage, one of the commonest patterns that are seen in glaucoma. A ring with a temporal crescent, or tubular field. So in tubular field, there will be like all the field is defect, or all the peripheral field is lost, but allowing only a central tubular vision, or the central fibers are preserved until the last of the disease. That's why this disease is like, it will be like a thief for the vision. It will, the patient will not be aware about the visual field loss until the late of the disease, where it will cause affection of the central vision. That's why screening is important and early detection is important. There are certain non-characteristic visual field defects. So when you find them in the visual field, you are more likely to think of another cause than glaucoma, like defects respecting the midline, like if the patient has hemianopia or quadrantenopia, or like bitemporal hemianopia or so. These defects are more likely to be neurological. Also, enlarged blind spot, it is more likely to be neurological, like in case of papilledema. And central scotoma, also more likely to be glaucomatous. So these changes, they could happen. Also, altitudinal defect could happen in glaucoma. However, they are not characteristic. So we need to watch out for the language used in the question. They are unlikely, but it is not impossible to have a patient with glaucoma with a defect respecting the midline, or enlarged blind spot, or central scotoma, or altitudinal scotoma. Centrocecal scotoma is a scotoma which will combine both the blind spot and the center of vision, or the fixation center. So if there is a scotoma which will be like that, it will be the centrocecal scotoma, like what happens in the toxic optic neuritis. We discussed it in the neuro-ophthalmology, so you can check it from there. Also, there is questions commonly asked in MCQs, which will be the last fibers to be affected. So we mentioned what is the early fibers to be affected in glaucoma, which will be the inferior fibers, infratemporal fibers in the from the macula. But the last to be affected will be the papillomacular bundle. That's why those patients will complain of visual loss late in the disease, and the infratemporal field. So papillomacular bundle, infratemporal field will be the last to be affected in glaucoma. Dr. Salma say it is in the very early stages. We could also have diffuse decrease in retinal sensitivity. Yes, Dr. Salma, that's correct. Finally, the investigations regarding the optic nerve head. So we have two kinds of tomographic evaluation of the optic nerve head. So it is these devices which will give us more data about the optic nerve head regarding the not only the retinal nerve fiber layer, the CD ratio, but also the thickness of the retinal nerve fiber layer in every quadrant, and also what will be the rim area, the disc area, the vertical and the horizontal CD ratio, and the cup disc volume. Two devices based on the same principle, optical coherence tomography and Heidelberg retinal tomography, and they will represent the thickness of the retinal nerve fiber layer by a circular diagram like that, showing the superior, inferior, nasal, and temporal with color code. So the green will be healthy and normal, the yellowish will be borderline, and the reddish will be outside normal for the age and sex. And this will also be represented by a graph that's called the double hump graph. Double hump graph, in which there is the superior, the superior, nasal, inferior, temporal. So normally the thickness of the retinal nerve fiber layer will take like the double hump appearance. So the thickness of the patient's thickness, retinal nerve fiber thickness, will be plotted against these data, and we will compare if the patient has normal or abnormal values. So the question here with which one should we use, like the OCT or the visual field? So both are important. So the OCT will be like an anatomical representation of the retinal nerve fiber layer, while the visual field will be a functional representation of the retinal nerve fiber layer. But however, each one of them will carry more significance in a certain stage of the disease. Like, for example, in the OCT, you can show detected changes in the retinal nerve fiber layer even before they be evident on the visual field. So OCT will be more helpful in early cases or in early detection of loss of retinal nerve fiber layer. While in the late of the course of the disease, there will be not very effective. Like if we are fine, can you hear me? Hello, can you hear me? Okay, so speaking about in the latest stage of the disease, like if we find that the patient has 50 microns of the retinal nerve fiber layer, so if it is less than 50 microns, this will not be helpful in the follow-up. Why? Because this is what's called the floor effect, that there will be, after less than 50 microns, there will be no further loss due to gliosis. The optic disc is becoming gliotic. So the less the thickness will not be representative of the advancing of the disease, or the disease could be advancing and the thickness of the retinal nerve fiber layer is still on 50. This is because of the gliosis. So in the advanced cases of the disease, the visual field will becoming more beneficial in such cases. Okay, so as a general rule, both should be ordered together, the OCT and the visual field. But for the early disease, the OCT is more superior. The late disease, the visual field is more superior. Okay, clear? Are you ready for the primary open angle glaucoma and other open angle glaucomas?